This was an important trial led by my colleague Dr. Stefan Grupp and a large group of investigators, of which I was part of the steering committee, in terms of a prophylactic study looking at the role of defibrotide in both adults and children in preventing new onsets of veno-occlusive disease in specific high-risk groups. Very challenging because this was an international study, multiple centers, and we had to adhere to a group of conditioning regimens and particular scenarios in transplant where high risk of VOD would be expected to occur. And in that context, patients were randomized either to defibrotide therapy as a prophylactic strategy versus best supportive care, and primary endpoints included incidence of VOD. One of the biggest challenges in the trial was also the way to assess VOD. We had an investigator assessment of VOD, but there was also an objective view through what was called an EPAC system that was done separately and in a blinded fashion outside of the trial and not at the bedside. In any event, there were over 372 patients enrolled, in fact, precisely 190 to the defibrotide group and approximately 182 in the best supportive care group. And the median age range for the defibrotide group was 13, reflecting the children in the study, and 15 for the best supportive care group, reflecting the same. In any event, whilst there was no new safety signal identified, it was clear that defibrotide was a very safe drug in this setting with no new toxicity signals and, in fact, an encouraging profile overall. The EPAC system, as it was called, basically was unable to distinguish any significant difference between defibrotide therapy and best supportive care in terms of preventing the incidence of VOD. However, the investigator group saw a higher rate of VOD SOS in the defibrotide treated patients versus the control group. And at the bedside, there was a significant discrepancy between what the investigators assessed and what the EPAC system did. Nonetheless, because of the nature of the trial and the fact there was an interim analysis, and if there was a meaningful difference seen, then the trial would continue, this led to the DSMB advising that the study should actually be closed. And I think what it really emphasized was the challenges of diagnosis at the bedside of VOD and how you would do that with an independent system. The second thing I think it brought forward was the issue of at-risk populations, because clearly at-risk populations now in the transplant setting are very different to what were regulatory standards when this trial was originally designed. And for example, one important subgroup who are not included and who are, for example, at our center, the largest group in whom VOD SOS occurs are those exposed to sirolimus as part of their GVHD prophylactic regimen. This group is clearly associated with a higher rate of VOD SOS, and for regulatory reasons they were not included. And for us, certainly at our center, that was a major challenge because it limited our enrollment to the trial dramatically. And it's in those patients that we've seen, not only do we see more VOD, but in fact we intervene early with defibrotide in these patients and consistently show benefit, as we published recently in our real-world experience. So I think there were some important lessons from Harmony in terms of trial design and study execution. The good news for defibrotide is no safety issue, but I think what was disappointing was not to see a significant difference that led to a call by the DSMB that this study could not continue because it was unlikely to meet its primary endpoint. And I think there are more lessons learned from these kind of experiences perhaps than from simple successes, but nonetheless it's important to contextualize the study because a meta-analysis of prophylactic studies in veno-occlusive disease SOS has been published, and that shows clear benefit to the use of defibrotide. And so when you set it against other experiences with defibrotide, prospective, randomized, phase 2 and phase 3 historically controlled studies, obviously the benefit's well established in treatment, so this doesn't in any way influence treatment, but in the prophylactic setting, it generates, on the one hand, a large body of experiences that suggest benefit, and on the other, a randomized prospective study in which methodologic issues, as much as anything else, have limited our ability to make stronger interpretations or conclusions.